Hi everybody, this is our video, step 1. We're going to learn about alterations in pulmonary function. So I apologize for the glitch in Collaborate. We'll try again next week. We'll either use Collaborate or Zoom so that hopefully whatever glitches I have are worked out. But in the meantime, we'll use our good friend YouTube to get us through. So what you should do while I'm doing this is have the guided notes printed or near you so you can reference them. I'm just going to add to it as we normally do. Okay, so before we get going, we want to think about what our respiratory system is really supposed to be doing. So remember, the two major functions of our respiratory system are going to be that we have gas exchange and then pH balance. Now we've been talking a ton about pH balance. The case study that I had mentioned in our quick recorded session that's in the folder, I'm going to send up an announcement about, is actually about pH balance, so to review some of the things that we were doing prior to break. So this is the thing that we want to think about now is gas exchange. So when we think about the respiratory system and its design, we need to think about what the parts are really doing, right? So first we have to think about all the tubes to get to the alveoli, right? You have the trachea, the bronchi, the bronchioles, and then finally down to the alveoli, which is our site of gas exchange, right? So those tubes have to be completely open because they're conduits for air. When we get to the level of the alveoli is when we're going to exchange gas. But a key thing about the alveoli, if we think about the alveoli as a membrane, which it is, right? It's a simple single cell layer thick. On the other side of there has to be some sort of blood flow going past to be able to pick up oxygen as it passes through the alveoli into our alveolar or pulmonary capillaries. So not only do we have to have air coming into the system, we also have to have blood flow through the system at all times so that as oxygen is brought in, it's kind of shuttled away from the alveoli and back into the general circulatory system, which is where we need it to go. On the flip side, carbon dioxide's got to make the opposite journey. Okay, so we want to keep this in mind as we're starting to talk about some of the things that can go wrong in the pulmonary system. And interestingly enough, we're going to talk a little bit about COVID-19 tonight, some of its effects on the pulmonary system. So if you look at the very top of the notes, it talks first about just general signs of pulmonary dysfunction. And this is really so we can all speak the same language, right? So the first word we see, it says dyspnea, which means difficulty breathing. Cough, abnormal sputum. So when you think about something green or red, that would be abnormal sputum. Hemoptysis, which means you're coughing up blood. Changing in breathing patterns. Changing in ventilation. Is it hypo or hyperventilation? So remember before break we were talking about this. If it's hypoventilating, you have a decrease in ventilation, decrease in rate and depth of breathing. If it's hyper, we're increasing the rate of breathing. We're increasing ventilation. When we say the word ventilation, we want to remember that we're talking about the flow of air, in this case, over the alveoli, okay? Cyanosis, which means you're turning blue. You have a bluish tint to the skin and to the nail beds. Clubbing. Clubbing is unique to the pulmonary system, okay? When someone has clubbing of the hands, it means that they have a pullback in their lower nail beds and a spoon-shaped appearance to the nails. And then finally, chest pain. Okay, so again, these are overall kind of general signs of pulmonary dysfunction and just some of the language, some of the words that we're going to use as we're talking about issues associated with the pulmonary system. All right, so let's talk about some of the conditions that can be established as a result of pulmonary disease. So the first one on your notes is hypercapnia. Hypercapnia means you have an increase in carbon dioxide level in the bloodstream. okay? And again, we're looking in arterial blood. In venous blood, we would expect to have an elevated level of carbon dioxide. What usually causes hypercapnia is poor ventilation of the alveoli. What this will result in, which we discussed several weeks ago, is respiratory acidosis. Again, we'll have that decrease in pH, which will hinder the binding of oxygen to hemoglobin, okay, which is going to be clearly then a challenge with getting the appropriate level of oxygen delivered to our tissues. Okay, so some of the causes of hypercapnia. So first one, we want to think about what is really controlling your breathing. Okay, so there has to be something in charge. Remember, the diaphragm, which is our major muscle that kind of governs changes in the thoracic cavity, is involuntary muscle. So it's got to be under control of somebody in the nervous system telling it what to do, right? So our breathing center is in the medulla. So if we have something, whether it's a drug or trauma to the medulla, if the breathing center is compromised, if we're unable to control our rate and depth of breathing, then obviously someone could could hyperventilate, and then they're going to develop high levels of carbon dioxide in their bloodstream. Some of the things that can compromise the functions of the medulla would be things like trauma to the medulla or certain drugs. Anything that's going to depress the central nervous system has the potential to depress the respiratory center. So two things that come to mind would be alcohol
and a spouse
and opiates. Okay, both of those depress central nervous system function and can depress the medullary center that controls your rate and depth of breathing. Opiates in particular, this is usually the leading cause of overdose deaths, is simply that someone stops breathing. Any diseases of the neuromuscular junction, so we think about why would that be the case. But remember, just having the nervous system function is one thing. It has to be able to talk to muscle and tell it what to do. So if something compromises the juncture between your phrenic nerve and your diaphragm and they can't communicate, you're not going to be able to change your thoracic cavity volume and take an appropriate breath in and out, okay? An abnormality to the thoracic cage, which we'll discuss when we talk about just chest wall deformities in general. Anything that's in the way, something obstructive, can lead to hypercapnia. So, for example, a tumor somewhere, again, within that conduit system, or sleep apnea. Okay, so let's talk a little bit about what apnea means, and then sleep apnea in particular, and talk about why this is the bane of my existence pretty much every night. Okay. Apnea means you have a condition where breathing spontaneously stops and then hopefully restarts again, okay? Apnea is usually associated with sleep. So what happens is individuals who have sleep apnea, when they drift off to bed, there's a relaxation, it's thought, around the muscles, around the airway, and so you get kind of compression of the space just before you're going in towards the larynx and the trachea, and because of that, airflow is hindered, okay? This is linked to snoring. A lot of people who have sleep apnea snore as well. There are certain risk factors for sleep apnea. One of them is obesity. Or if people have a lot of weight around their chest cavity or around their neck, they are at risk for sleep apnea, okay? Now, obviously, you would like breathing to spontaneously start up again, but in some cases it does not. So sleep apnea can be fatal in some individuals. What is the treatment for it?
sleeping in different rooms.
Right, so Jake just suggested that you sleep in different rooms. That's a perfect treatment. I don't know how good it is for your marital bliss, but It certainly makes your wife happy. The treatment is, and Jake should listen to this part, it's a CPAP. Okay, what's this?
Pap smear.
This is a machine that you wear at night. It stands for continuous, so that's the C, positive airway pressure system. This is a positive pressure ventilator that keeps your airway open. You wear it over your nose and mouth at night, and the machine kind of forces just slightly pressurized, positively pressurized air into the lungs. And again, is meant to kind of force the airway open a little bit and make breathing a little bit easier all night long. So then the next question you all should be asking yourself is, why doesn't Jake have one of these? I don't know the answer to that. Okay, so maybe he can come in later as a guest lecture and explain himself. Okay, it's going to be pillow night one night. Another thing that can cause hypercapnia. Another thing that can cause hypercapnia, which we will talk about at great length, is emphysema. So many of us know emphysema because emphysema is linked to smoking. However, there is a genetic form of emphysema that has nothing to do with smoking. So we're going to talk about both types, primary and secondary emphysema, when we cover that. Okay, so when someone has hypercapnia, what are the outcomes? So we've talked about some of the causes. Let's talk about the outcomes. You would have things like a decrease in pH. You'd have respiratory acidosis. Electrolyte abnormalities. Secondarily, you'd have very low oxygen levels as well. You would be hypoxic, and cerebral vasodilation.
That sounds like good stuff.
Cerebral vasodilation, we think, that seems odd. Why? Okay, well, because your brain is feeling like it's being deprived of its oxygen because you have secondary hypoxia. So because of that, it's going to dilate those blood vessels to try to increase blood flow to the brain to ensure that your brain gets adequate oxygen. And remember, when your heart is pumping, we're going against gravity to get to the head, so it can present some challenges. Okay, so if we vasodilate, we kind of get over some of those challenges. Okay? All right, another condition that can result from pulmonary diseases, and again, this is very general, is hypoxemia. So let's talk about that for a minute. Okay. Hypoxemia is when you have a reduced concentration of oxygen in arterial blood. This can be caused by a couple of different things. So I've outlined three kind of general things that could contribute to hypoxemia, okay? These are kind of easy ways to identify in your brain three simple spaces where we would have issues within the pulmonary system that could potentially cause there to be a drop-off in the amount of oxygen being delivered through that system. So we could have a change in oxygen delivery to the alveoli. There could be something obstructive, for example, okay? That's going to change the way that oxygen makes itself towards the alveoli, okay? Then there could be an issue with diffusion. As I said when we first started talking about this, not only does oxygen have to arrive at the alveoli, it needs to pass through the alveoli and diffuse into the bloodstream. If there's anything that compromised that diffusion, let's say there was some fibrosis of the alveoli, right? It's going to make that process more difficult, and that certainly would result in hypoxemia. And then poor perfusion. Again, you have to have appropriate blood flow through those alveolar capillaries so that once oxygen passes through the alveolar membrane into the capillaries, it's able to be carried out of your lungs back towards the heart and then back towards the systemic circulation. If your lungs were poorly perfused, then you certainly would have an outcome that would be hypoxemia. Okay. So things that could contribute to hypoxemia would be hypoventilation, of course. If you're not ventilating the alveoli, it's absolutely going to cause a drop-off in arterial oxygen. When you're in an area of decreased atmospheric oxygen, For example, at high altitude, that might cause mild hypoxemia. Now, obviously, this is why when people are going to areas of elevated altitude, or if they're going to hike at very high altitude, you do something called acclimatize before you decide to do your ascent. So you give your body a chance to adjust to the change in atmospheric oxygen as you go up in altitude. Obviously, a COPD is going to result in hypoxemia. We're going to discuss COPD as a topic all unto itself. Okay, how do we assess this? How do we assess what's really going on in terms of delivery, perfusion, etc.? All right, we can look at something called a VQ quotient, which we do through a VQ scan. Okay, what this looks like, it looks at is the ratio of ventilation to perfusion. These should be roughly equal, which we could think about in our minds. That makes sense. For as much as you ventilate, you want to perfuse enough blood through the area so that you would have adequate delivery of oxygen through the alveoli into the bloodstream and then back to the heart and back into the systemic circulation. So there's two results that we could see here. You could have a decreased VQ ratio, which means you have lower ventilation but good perfusion. This would happen in things like asthma, would cause a low VQ ratio. Okay, pulmonary edema. If you have fluid in the way, obviously you're not going to ventilate very well, so that's going to cause a decrease in your VQ ratio. Pneumonia. Would also cause a decrease in your VQ ratio. Something that would cause an elevated VQ ratio, meaning your ventilation is just fine, but your perfusion is lower than ventilation. It's not matching ventilation. Would be something like a pulmonary embolus. In the case of a pulmonary embolus, right, you would have, in this case, you would have a disruption of blood flow, so that's why the perfusion level is going to be lower than the ventilation, which would be normal, okay? This is one way that you can assess where the issue is when your patient has hypoxemia. So some of the signs and symptoms that someone would have hypoxemia is obviously they would be cyanotic. They're going to have tachycardia, which is compensatory. Their heart rate will be elevated because their body's getting the signal they're not getting enough oxygen, so your heart is going to do what it can, which is going to be to pump harder to try to increase cardiac output and circulation. And then confusion. When someone has hypoxemia, obviously because of the challenge of overcoming gravity, to get adequate blood flow to the brain, and if that blood flow to the brain has the inappropriate amount of oxygen, it's going to lead to confusion. Okay? So again, this is another thing that can occur when you have these kind of broad pulmonary issues. So hypercapnia would be one, hypoxemia would be another. In your notes, I've also given you guidelines for what acute respiratory failure looks like. I don't really care if you know the numbers. I would never ask you to recreate that, but you can see that you have low oxygen, elevated CO2, and a decrease in pH. Again, this can be caused by any number of things we're going to talk about, but when someone goes into acute respiratory failure, one of the things they will need is ventilation and supplemental oxygen. Okay. The last thing we're going to talk about before we take a break is we're going to go into some disorders of the chest wall, structural disorders. Then we'll go into pleural abnormalities in the next video. So one of the things we want to remember when we're talking about the thoracic cavity is the thoracic cavity was designed with kind of ventilation in mind. So remember, you have your rib cage, the sternum, the costal cartilage, then the muscles in between, and then the diaphragm. When we breathe in, okay, remember humans use a negative pressure breathing system. When we breathe in, you have expansion of the chest cavity so that you set the stage. So oxygen will flow one way in and carbon dioxide upon exhalation will flow one way out, okay? If someone has a change in the way their thoracic cavity is structured or a restriction in their chest wall, then it's going to challenge their ability to take appropriate breaths. When you have a thoracic cage abnormality or a chest wall restriction, the treatment is going to depend really on what you have and what caused it. The outcome will be, very generally, you'll have a drop off, a decrease in tidal volume. Which is the amount of breath that air that someone takes in upon inhalation and exhalation. So if you have a decrease in tidal volume with every breath, you're obviously not getting enough oxygen and not forcing enough carbon dioxide out. So someone could have a skeletal deformity, whereby their chest wall, the physical structure of it is not normal. Trauma. If you look on Blackboard in our videos of interest folder, you're going to see a short video about something called a flail chest. And a flail chest, if you've not heard the term before, very general means that a piece of the rib cage has broken with trauma and it can lead to a punctured lung. Okay, if someone is immobilized, it can lead to restriction of the chest wall if they're laying in a certain position for too long, can't get up, can't move. Okay, patients who are sedated, for example. Someone who is obesity can cause restriction of the chest wall, and of course that would cause some difficulty breathing and would absolutely cause a change in tidal volume as well. Or impairment of muscle function. Again, because we rely on not only your diaphragm, but the muscles all throughout the chest wall to assist with taking breaths. If there was any impairment to those muscles or damage to the nerves that service them, then that would obviously cause a restriction in the ability for your patient to take an appropriate breath in and out. Okay, I'm going to pause there and we'll start our next video on pleural abnormalities.